hemorrhagic shocks, about
Mm-hmm.
the bleeding from the GI.
Oh, yeah.
Okay. Treatment with the surgery and use uh, some surgery or not surgery in uh, GI bleeding.
Oh, perfect. Yeah,
Okay.
that's very, it's probably better to do anything is better in person probably than the Zoom meetings.
Okay.
Well, we'll give it a few minutes and see if anybody else shows up, unless you guys know this is all that's going to be here. But oh, yeah, we'll give it like 3 more minutes at 8:05 or my time. Then we'll start. And yeah, it'll probably be pretty brief this week, just because I know you guys, I was from the emails, I think you guys just covered trauma, which is a lot of this. So. I'll have access to the chat too if anybody has questions. It's a very small little lecture, but we'll go through it fast and do some questions, and then I'll probably just go ahead too and share this slideshow so that anybody who missed the lecture can see it if they want to as well for any reason. Yeah, I don't think anybody else is going to show up because everybody's usually pretty on time. So I'm going to go ahead. Oh, we got one more person. Well, we'll go ahead and get started. So this week in the shock lecture series, we're going to talk about hemorrhagic shock. And really, hemorrhagic shock is just referring to a specific type of hypovolemic shock. So if you're looking at shock, kind of classifying it in a different way, like we talked about before, yeah, some people will just call it hypovolemic shock. But when we're discussing hemorrhagic shock, it's obviously due to severe blood loss. The blood loss will also it'll eventually cause decreased perfusion and oxygen to vital organs, causing significant amount of damage. The blood loss can be traumatic, which is usually one of the more common causes, but it can also be from GI bleed, vaginal bleeding, secondary to pregnancy or delivery, or it can be from vascular complications, which are a little bit more rare for something to cause that much bleeding. But if you have an aortic aneurysm that ruptures or another major vessel, it can cause enough blood loss to cause a hemorrhagic shock. So the pathophysiology is fairly straightforward. It's because of blood loss, and the blood loss is causing decreased perfusion. But there can be some secondary factors at play. The hemorrhage will lead to vasoconstriction. So your vessels will constrict blood flow to other organs to kind of salvage those vital organs whenever possible. And so that can worsen the decrease in perfusion. When we start to get this massive amount of blood loss, it can also cause the clotting cascade to kind of go into whack, and it can cause a consumption of platelets and other clotting factors. And so it makes it really difficult to get any type of clot where you need it to be, but then you can get clots in places where you don't want them to be as well. And then the severe blood loss can cause an immediate and kind of later on down the road, kind of a similar response to what we see with septic shock or the SIRS, where you get this whole systemic inflammation, and that can cause secondary complications of trauma or blood loss, like infection, like reactive oxygen species being released and causing more damage and just making things worse. So for the diagnosis, this does tend to be the most straightforward of all the shocks to diagnose, because it's usually fairly obvious when somebody is in hemorrhagic shock. They have an obvious wound that's bleeding a significant amount. They've had a traumatic event that becomes obvious that they have internal bleeding, or they come in and they're telling you, I have a GI bleed, I've been bleeding out of my bottom, or I'm having hematemesis, throwing up blood. It's usually pretty obvious based on their history and their physical exam. The only time it can be a little bit less obvious is if somebody has had, and this usually comes with a GI bleed, where somebody's been bleeding for a longer period of time, usually out their rectum, and doesn't really know, and then their blood loss becomes more severe, and they've been compensating, their body's been compensating, and then they eventually just can't compensate anymore, and they go into shock, where they become hypotensive and they just can't sustain anymore. So for the physical exam on this one, I mean, when you're doing physical exam, a lot of the times you're treating at the same time, and that's, really important with shock. So you're evaluating them, but you're also doing any interventions that can be done. So if you see something bleeding while you're doing your assessment, before you're even done assessing them, you're going to want to apply pressure. You're going to want to help the bleeding stop. So with any type of bleeding, they're kind of new, like algorithm or thing that people talk about is called the March algorithm. So it's used with ABCDEs. It's kind of a different assessment, like a trauma assessment, as opposed to with your critical patients. And you're just going to assess the hemorrhage first, because that's going to kill the patient if you don't address that massive hemorrhage. But then you go right down into your airway, your breathing, your circulation, and your hypothermia. And with that March, that hypothermia is just referring to getting the patient covered, making sure that they're warm and they don't become cold and they're shivering, and that can exacerbate all the other complications. A lot of that marches to it. It's from data that people got outside of the hospital, so in battlefields and out of hospital, like EMS data. And so that kind of applies to us too, because we're the first line for a lot of these people. And this is one where you do want to get every resource you can. And it sounds like for you guys in Vietnam, a lot of you are at bigger centers, which is great. But in these ones, just get the help that you need, because you're going to need people running to get blood products. You're going to need somebody holding compression on a wound, possibly. You're going to need multiple nurses starting IVs. So these are ones where you just need to get as much resources as possible, and not be afraid to just get everything you need or treat that for treatment and for assessment. So the labs to order, and just going back to that last slide, but the other thing too is that as you're assessing them, evaluating them, these are patients where you can have a lower threshold for intubation if they have a massive hemorrhage, just anticipating what's next for this patient, where they're going to go, what they need, but also can help calm them down. It can help address pain control. It can help just kind of take away that secondary complication of being hypoxic, and can help you make sure that you're getting them the oxygen you need, at least from that perspective. So when we're evaluating them, getting the labs, just kind of all those basic labs, but it is really important on these ones, if you can, to get like point of care blood gases. You need baselines for these people, see where they're at, see how, and if they've been losing blood for a long time, then you can kind of give you an idea of their base excess. So if you look at a blood gas and you look at their base excess, if it's really large, that can be an earlier sign of blood loss than a hemoglobin or hematocrit might be. So that is a great first tool, and you can usually get it really fast. It's important to get their electrolytes, especially if you're going to be transfusing blood, just to see where your baseline is, to see what they need to optimize those values. Coagulation studies are also valuable, just especially if you're giving blood products and you are anticipating that this patient's going to get blood and they might become hypercoagulable, and gives you an idea. Then ultrasound is a huge tool, and these definitely a friend for if they don't have an outward sign of trauma, but you know that they were in a traumatic event. You can always do your fast, see they have a lot of blood in their abdominal cavity. Remember, it's about 500 mLs of blood is going to be or will give you a positive fast. So you need a fair amount of blood to have a positive fast, but if you do, it's highly indicative of an intra-abdominal injury and one that needs to be addressed immediately. And then the rush exam, and that can be used in patients, even as part of your secondary trauma survey if the injury isn't obvious for the patient, and then definitely on somebody with a GI bleed, or something like that. I was just kind of looking. So the magnesium for the hemorrhagic shock, I usually will do a magnesium on these patients. It doesn't come standard in the CMP. And some of that is just getting initial labs. It's one that I like to get early on because it doesn't come with your regular blood tests. And if it's low, then your potassium is not going to be absorbed properly if you have to replace potassium. And if you have an intra-abdominal injury or any other injury that's going to go to surgery, it will diminish healing, especially intra-abdominal healing. And then that smooth muscle healing won't be as effective if your magnesium is low, because it plays such a critical role in how our smooth muscle functions. So for me, it's just one of those, when I'm looking at sicker patients, because it's not part of the CMP, I oftentimes will order it so it's not missed down the line. The other thing, and we'll get into it, is with the massive transfusion protocol, a lot of times this will deplete the calcium because of the byproducts that are in some of the blood products that we're giving, and the nature of giving a lot of blood, your calcium will be depleted. So you're giving a lot of supplemental calcium. And if your magnesium is low, it won't help you. You won't optimally absorb the calcium either. So for those reasons, that's all. We'll just check it, and it's an easy thing to replete if it's really low as part of your kind of more tertiary treatments for these patients. So then the imaging, a lot of times the imaging for those, sorry, I clicked forward and I have a hard time clicking back on this, but the imaging is going to be directed to where the injuries are. If you are at a trauma center, sometimes they do just kind of bulk imaging on these patients where they do head to toe. It depends on your trauma service. If you're the one taking care of the patient, you can do directed imaging, and sometimes imaging isn't necessary, just taking the patient to the OR or then moving forward with treating the patient. Things for us to think about is always going to be the pre-hospital treatment, because we do get a lot of these patients, and that's one thing we can open up to discussion. I'd love to hear from you guys in Vietnam what the pre-hospital kind of protocols are and how your EMS people treat these patients. Here the biggest thing for them is going to be doing whatever they can to stop the bleeding. A lot of times they will start some fluids, and it's not very often that they have blood products. There are some EMS services in the United States that do have blood products that they can administer if something is bad, but it's not very often. And they usually have to have a paramedic level with them. And again, so that it's very limiting. And so sometimes they don't do that. The blood products expire too quickly. That becomes a problem. So they can't keep them properly stored. So it becomes wasteful of the blood products, which is why it's not done that often. sometimes this becomes education for your EMS people. They don't have the blood to give. And even if they know it's not the most ideal, if you have a longer transportation, sometimes you'll see people that, and they've gotten a lot of just normal saline or lactate ringer. So you have to be very, cognizant when you're getting these people from EMS or an ambulance service, how much fluid they've gotten. Because if it's a long trip, sometimes they've already gotten 2 liters of just normal saline or lactate ringer, which is too much in these patients. So you want to make sure you're not giving them any additional just fluids. One thing they can give is TXA or transischemic acid. And a lot of the medical services or ambulance services will give this, especially if they're picking the patient up within 3 hours. And that's because the most ideal time to give this medication to help the body form the clot to get the bleeding to stop is when it's given within the first 3 hours. So since these people are seeing them much quicker than we are, a lot of times it's very beneficial if they can give it. But they just have to get to where the patient can be treated definitively. And with trauma, that's what all the data shows. And that's why, trauma centers are a thing, is because the patient is going to do the best when they're at a trauma center where they have the ability to get the definitive treatment as rapidly as possible. So diving into treatment with these, direct hemostasis, so pressure dressings, packing, tourniquets, or binders, if you're doing a pelvic binder. So just remember with tourniquets that you don't want to have them on for much longer than 30 minutes unless you absolutely have to. If a tourniquet has been in place for longer and you're dealing with a larger extremity, just make sure that you do remember that there's probably been some ischemia to that limb. And if you're releasing, when there's ischemia, you have byproducts, one being potassium as well as lactate. So if you remove a tourniquet that's been in place for longer than 30 minutes, you may end up seeing more severe acidosis or hyperkalemia. So those are things to watch for and that need to be treated immediately. So again, a reason why blood gas is great in these trauma patients, because if you've had a tourniquet on something, you can check those and be ready to treat them immediately. So if you have a hyper K or you're worried the tourniquet's just been on so long, be ready with calcium. So that's going to be your most immediate treatment. And then for the pH, you can treat with bicarbonate if you need to in that immediate setting to give that your body time to flush out that additional bicarb that's built up from the tourniquet being in place. Definitely going to need IV access. So depending on the severity of bleeding, 1, 2 IVs, and then maybe even a central line type of thing. For trauma, we have trauma lines. I don't know if you have those there, but you got to remember that you need something with a short length. So a traditional central line is actually going to get you blood slower than an 18 gauge IV in the AC. So those aren't very effective. If you have a trauma line, which is a short, very large diameter catheter IV that you can place into the femoral vein, that's really effective. Or sometimes just traditional, and you can use an IO as well, but those are fairly thin. I believe they're pretty thin diameter. And so you're going to get blood slower than you would through a traditional IV, but it's still faster than a central line. And then the volume resuscitation, we kind of delved into this, but you need blood. If you're losing blood, you need blood, because it's giving too much crystalloid or the normal saline or IV, it's just not going to be effective, and it can really complicate things down the line. And you can't, so giving blood products, I think my next slide kind of we'll talk a little bit more about like a massive transfusion protocol or the specific blood products. One thing they're using now is more like a whole blood for trauma or acute severe blood loss. So that's just, instead of separating the different factors of the blood, like RBCs and plasma and platelets, you can just do the whole blood. So treating somebody's blood pressure with vasopressors has just never, unfortunately, been shown to really benefit mortality, because sometimes it's false. You give them, if you give a vasopressor, sure, you're going to help the blood pressure a little bit, which could potentially help you with perfusion, but you could convince yourself and undertreat the blood loss. So you put somebody on norepinephrine, well, great, their blood pressure looks better, so you maybe stop giving them blood products, when the reality is you should just be giving more blood products to adequately treat their blood pressure. And then I see the note that you guys do not use the REBOA, the resuscitative endovascular balloon occlusion of the aorta. That's it. I've seen it, and it can be a little bit messy anyways. You have to be very proficient. So what they do is they go through the femoral artery, and then they will thread the femoral artery with a catheter, similar to what you would do, like how you start a central line. And then that catheter goes in, and when it's suspected to be at the aorta, they blow up the balloon, and that clamps the aorta. So essentially, it does the same thing as if you were going to do a thoracotomy, which is if you know somebody has major intra-abdominal bleeding and they've had a cardiac arrest, you're just going to open the chest. And if you can't immediately find the bleeding, then you clamp the aorta. So the REBOA is going to do the same thing as clamping the aorta. And so those are two things that you can do if it's major intra-abdominal trauma and you have a cardiac arrest. The caveat being, I think for a lot of us, we work at trauma centers. And so there's a trauma surgeon that's going to be assisting and making these decisions and doing that. Because with the REBOA or with a thoracotomy, you can only have the aorta clamped for a maximum of 30 minutes before it's unsalvageable. So you only have 30 minutes to get these people from the ER into a trauma bay where they could have definitive treatment. And that's pushing it, because they have to be 30 minutes to the time you're unclamping that aorta. So really, it just needs to be a very rapid thing. And so if you're out by yourself as an emergency medicine doctor, you're not likely to do these things, because there's just no way to get this patient the definitive treatment that they need. Opening the chest for a penetrating injury may be different. If you think that you can find the injury and treat the injury itself, then you would actually have longer than if you're just trying to get in there to clamp the aorta to stop intra-abdominal bleeding. Pretty secondary thing, but these patients that have traumatic blood loss would need a tetanus and likely antibiotics as well. And then, I didn't really get into the GI bleeding side of treatments, because that's kind of a totally different topic. And you could have, and I'm sure there is an entire lecture on GI bleeds and treatment, same with pregnancy related complications and treatments. All of those you would need to gear your treatment towards that. And a lot of times it's surgical. So with GI, treatment's going to be taking them to get an endoscopy or a colonoscopy for banding of varices or cauterization for pregnancy. It's taking them to the OR, or not pregnancy, but pregnancy related things. So after deliveries, or sometimes delivery of the baby is the treatment. So you just have to kind of gear your treatment of the hemorrhagic shock to whatever you can do to stop the bleeding. As far as the hemorrhagic shock component of it, the biggest thing for us is administering blood. We're the ones that are leading the resuscitation and making sure these patients are getting the adequate amount of blood product that they need and in the right way so that they have the best possible outcome. So in the United States, and I'm sure you guys have something similar, whether it may be just called something else, is we use massive transfusion protocol. And how you distinguish that and what kind of makes it a massive transfusion is when you're replacing the one or more of the body's total blood volume, or more than 50% of the blood volume in a 4-hour period. The average blood volume for an adult is about 5 liters, and that obviously is going to fluctuate depending on the patient's size. So you're talking about, giving them at least 5 liters of blood. Well, I put this chart in here too, because I always forget how much of what the actual quantity of blood is in these units of blood. So for us, when we're talking about giving units of blood, to me, it always seems a little bit arbitrary, and I'm sure there's a reason for why the blood is packaged the amount that it is, but I'm not sure why. And so I kind of put these values in here for reference for you guys and for myself to review how much blood. And then that can also kind of give you an idea how many red blood cells, how many units are you going to need to get to this 5 liters of blood. So 1 unit of blood is 350 ml. So usually we're not dealing with massive transfusion until you're over, you're looking at almost like 6-7 units of blood. So quite a few units of blood. For us, whenever you do start a massive transfusion protocol, or once you're getting to more than 2 or 3 units of packed red blood cells, you want to transition your blood product administration to a ratio of 1 to 1 to 1 or 1 to 1 to 2 of platelets, plasma, red blood cells. So really, I've always done it as 1 to 1 to 1. So you don't need to do that for your first unit or even your first 2 or 3 units of just packed red blood cells. But once you're getting past that, you really want to make sure that you're administering platelets and plasma so that you're not diluting your blood and you still do have some clotting factors in there, so that you're not kind of throwing off the balance and giving somebody and diluting the blood too much with just red blood cells. Like I was kind of saying before, I've seen some stuff where some places and like newer ideas where they're just trying to administer the blood as a whole blood for trauma. The kind of secondary things once you're starting this massive transfusion is remembering that the blood is frozen. So even though that you're getting it thawed and it's not, it's still, when you're just sitting there, it's going to be colder than the body's core temperature. So if you give it, especially if you give it without a warmer, then you're going to be cooling the patient as you're replacing their warm blood that's been running through their circulation with colder blood that's been sitting out. Here we do have a fluid warmer, so a level 1 transfuser where you put the blood product in and it warms it as it's administering it very quickly as well. So that's a great thing that they're doing now. If they're not just trying to get that blood warm, then make sure that you're keeping the patient warm, that you're aware that their body temperature may drop. So you just have to be cognizant of that. The other major thing you'll see is a hypocalcemia with these patients. And that's because the plasma product contains a citrate that chelates calcium. So it just destroys the calcium. So you can either just know that that's going to happen if you don't have like a bedside way to do a venous blood gas with electrolytes or rapid test of calcium levels. You can just kind of know that you're going to need to replace 1 to 2 grams of calcium for every 6 units of blood. Or you can just go ahead and give calcium and treat to the actual number. So you can get these rapid blood gas or point of care blood gas with electrolytes. And when you see the calcium is low, continue to give it. And then the pH, you're going to have to just be checking this with giving blood products. And because of the hypoperfusion from the hemorrhagic shock, these people are very often going to be acidotic. And so these are and we don't always use bicarb to treat acidosis immediately, but in these patients, it can be necessary and it can help save their life. And if their pH is too low, their bicarb is too low, it can worsen their hypotension, worsening their shock. And so giving bicarb frequently can be beneficial too. So Yep. And then moving forward, and some of these complications, we've kind of talked about it already and geared into it. And sometimes these are things that we just don't deal with in the emergency department, because by the time these complications happen, they're long gone. They're in the trauma ICU or the surgical ICU, or they're in the OR and they're out of the emergency department. But being aware of them is key, because there's things that we can do while they're in the emergency department to limit these down the line. So big thing is the overuse of crystalloids. It does cause this delusional anemia, and it can make their coagulopathies worse. So it makes them unable to form blood clots. So then they just keep bleeding. And then it can also cause that it can worsen the whole systemic inflammation. So really limiting your use of crystalloid fluids. A lot of trauma surgeons I've worked with, they say don't use more than 1 liter of normal saline or lactate ringer. And they really don't need any, because they're not losing fluids, they're losing blood. But it can help just with all those other losses, and can help us bring the blood pressure up. And a lot of times I think it's done because it just makes people feel better when they don't have blood products to be giving something. So we just don't need to continue that in the emergency department when we do have blood products available. The one thing would be GI caveat might be a GI bleed. With the GI bleed, you can probably get away with a little more, because if there's associated diarrhea and the blood is coming out of the rectum, we're probably also losing stool and other byproducts and fluid, and they've been sick and they're vomiting. So it's not as, I think 1 or 2 liters with the GI bleed is probably not going to cause the same issues as with trauma, because with trauma, you're just losing blood from a traumatic injury or source. Avoiding the cold blood, like we talked about, because we don't want to make the patient hypothermic. Making somebody hypothermic will worsen, it can increase their long-term mortality or morbidity. And then, the acidosis, like we talked about. So we're just kind of rehashing some of these same things, but just knowing that if we look for these things, we treat them when they come up, we can really help the patient down the line. That kind of wraps up the lecture, and try to just focus it on the hemorrhagic, the shock part of it, and how we're treating it as emergency medicine doctors. But so I'll see if anybody has questions, but we can dive right into this one. 35-year-old male presents after a motor vehicle collision with hypotension, tachycardia, and altered mental status. Which of the following is the most appropriate blood product to administer immediately? So A, type O negative cross-matched blood. B, type O negative uncross-matched blood, or type O positive cross-matched blood. That's a tongue twister. Even for me, and English is my first language. Type O positive uncross-matched blood. You can answer in the chat. You guys all have to answer today, because there's only 4 of you. Well, I answered, but okay. Sorry, I didn't mean to click on it. But yeah, so this one is going to be D. And the thing to remember here, it's type O negative, type O positive uncross-matched blood. And the reason in this patient why we're using the type O positive is because it's a male. So in any female that's childbearing age, you want to make sure that you're using type O negative. And that's in case the patient's pregnant, and if the patient plans on having any more children, you want to use the type O negative, so that she does not develop the antibodies against the blood products, so that if she has a baby that happens to have a different blood type than her, then the baby will be safe. So for males, you can go ahead and use this you can use the type O positive and not worry about it. And then you save that blood product. Yep, it can be, and then you want to make sure that it's just looking at the different responses. You want to make sure it's cross matched, and that's just because you're not going to have time. So if you have time and you can cross match their blood, then that is the most ideal to give. But in this patient, you're probably not going to have time since they show up with hypotension, tachycardia, and altered mental status. So you're not going to have time to wait for that type and screen on the patient. You're going to want to just treat them immediately with blood products. So next one, 46-year-old woman presents as a restrained driver who required prolonged extraction from a high-speed motor vehicle collision. In the ED, her heart rate is 125 beats per minute, blood pressure is 80/50, respirations of 22, pulse ox 97% on room air. Exam reveals mobility of her right iliac crest and a large volume of blood in Morrison pouch on the fast exam. Chest radiograph is normal. 2 large bore IVs are placed, fluid resuscitation is initiated, and blood products are ordered. Which of the following is the most appropriate next step in the patient's management? So this patient has a positive fast exam. So they are going to need to go to the operating room for a laparotomy. So yes, she does have mobility of her right iliac crest. So she probably has a pelvic fracture that might need a binder. And so you would probably think about doing a pelvic binder. This one's tricky. I think for you is for external fixation, it's typically, I think they're going to mean when they say external fixation, they're talking about something more permanent for a leg. So for us, if you have a leg or an arm fracture, then you would put on an external fixator. If they were talking about a pelvic binder, it probably would have said pelvic binder. You're absolutely right when you say unstable pelvic fracture. So you would put on a pelvic binder. And had the question said initiate placement of a pelvic binder, then I think that you would have been right, because right there in front of you, you could have placed a pelvic binder. And I think that's just a nuancey vocabulary, American thing that when they're saying external fixator, they're referring to if there had been a fracture that you see. The one that's going to kill her is that blood in the abdomen. So whatever is bleeding, which she has a right iliac crest injury, she probably has an injury to one of the vessels in the common femoral region. So either common femoral vein or artery is probably injured internally, and that needs to be fixed. So even though you're right, you're going to put a quick pelvic binder on her, absolutely, in the emergency department, and that's going to be done before. So I think you're right on that one. As that's happening, the patient needs to go to the OR to get that laparotomy, to get the abdomen opened so that they can repair the vessel that's causing that bleeding in the abdomen. But I think when you say unstable pelvic fracture, pelvic binder, you're totally right in your reasoning. And the whole idea of these questions is to get us thinking about our steps, and that would be the next step. So next question, 25-year-old male presents after a tractor accident. He is found to have a large wound in the left lower extremity with a large amount of active bleeding. Vital signs are blood pressure of 80/50, heart rate of 125, respirations of 20, pulse ox of 90% on room air. What is the most immediate action that needs to be taken? Absolutely. So everyone got that one right. The B, so compression of the bleeding wound. You have to put pressure on that wound. If it's a large amount of active bleeding, that's going to kill the patient rather quickly if you don't put pressure on the wound, get the bleeding to stop. And, these trauma patients, they're one where you're going to have lots of people in the room. You're going to have every resource that you possibly can get. You're going to be putting them on oxygen at the same time. You're going to be giving them some, hopefully, blood products after this one, not IV, regular IV fluids, but you're going to be giving blood. You're going to be putting them on oxygen, and somebody's going to be pressing the wound all at the same time. The CT of the extremity, probably not going to happen until that bleeding is controlled, because it's just unnecessary if you see what's happening right in front of you. Later on, once that bleeding is stopped, once the patient's blood pressure is improved, might be something that's done. And next question. 55-year-old male with past medical history of hypertension and alcohol abuse is triaged to your emergency department for 1 day of multiple episodes of bloody vomitus. Patient denies any abdominal fever, any pain, fever, chills, chest pain, syncope, or change in stools. Patient denies any history of similar symptoms in the past. Patient reports poor compliance with his hypertension medications and affirms that he drinks 1.5 liters of vodka per day for the past several years. Upon initial assessment, he is pale, but in no pain or respiratory distress. His vital signs are blood pressure of 85/60, heart rate of 120, respiratory rate of 18, satting 98% on room air, and he's afebrile. So first part of this question, patient is initially given 1 liter of normal saline with no change in blood pressure. What fluid should be administered next? So you're going to give him packed red blood cells, additional bolus of IV fluids, platelets, or lactate ringer. And great, yep, everybody got it. The packed red blood cells. So just put in here as a reminder, if somebody is bleeding and they have this hematemesis where they've had this vomiting blood, you need to start giving them packed red blood cells. The fluids are just not gonna be what this patient needs at this time. Oh, sorry. Well, I think in the other part I put that, but yes, excellent. So I think I put a second part to the question, but it's okay if we skip it. And then this is the last question. So 82-year-old man is admitted after being involved in a motor vehicle collision. He has severe chest and abdominal injuries. His head and extremities are only minimally traumatized. He undergoes surgery for a splenic rupture. After 8 hours, he becomes hypotensive and febrile and is intubated because of respiratory failure. He rapidly develops disseminated intravascular coagulation, DIC. Which of the following is the most likely diagnosis? Yeah, this question is hard. Yeah, so this question is tough, and the answer is actually septic shock. So it's it's fairly quick, but this is kind of probably somebody who had this, he had surgery, had this splenic rupture, and then he develops from the surgery, from also probably blood products and the initial hemorrhagic shock. So he kind of has both, but in this case, he becomes hypotensive and febrile and then goes into this DIC. So this is more of a septic shock picture because he's febrile, because that blood loss has already been treated. So you have to imagine he's had this surgery, he's had this splenic rupture repaired, he's probably not bleeding anymore. So his hypovolemia has been addressed already. So that's not the cause of his hypotension in this right at this time. So because it's secondary, he's already had the initiation of treatments, but now he's getting hypotensive again. This is probably more of septic shock. Now, is there already an infection going on? Probably not. It's probably not totally from infection, only 8 hours after surgery. Might have been longer since the accident. You know, it's hard to say, but part of this is the whole resuscitation and actual blood loss. They can cause that systemic inflammation throughout the entire body where you're getting it's, you know, and then you get this, all of the clotting pathways go crazy. So you can get into DIC like this, where you're throwing clots everywhere, and your blood gets too thin and you're throwing clots. So you get DIC and sick, and then you get a fever because your immune cells are all hyperactive from this SIRS response. And so you're releasing cytokines that cause that fever. And then that will also give you that hypotension from the vasodilation that would occur. So in this secondary, then there would be some necessity for giving some IV fluids. So not necessarily needing to give blood products for this secondary incident, seeing if he does need blood since he's going into DIC, also fluids, also antibiotics. And in this patient, he would need pressors, so a norepinephrine, and it would be beneficial. So that's why it's important to distinguish. But this would be a really tricky one to hash out. And you would want to get more imaging, at least I would, to make sure he isn't rebleeding from his recent surgery and to make sure there's not something else that you're missing. So very hard question, but just remembering that these trauma patients and these patients that have had hemorrhagic shock, they become really, really likely to develop infection down the line. They get really sick, and they can be sick from the injury itself, from all of the resuscitation that they received, all the blood products they received, the procedures they had done, being in the hospital, being intubated. So just really complicated patients, and how you treat them in the ER really can change their hospital course, and then they're likely to survive from these injuries or bleeding events. So that kind of wraps it up for me. Does anybody have any questions this week? Does anybody from the Vietnam side of things want to tell me for you guys what I'm really curious to see, like if your EMS has, or your ambulance services, how much treatment do they give these trauma patients? Do they start them on just fluids? Do they have blood products for them? What is their usual, or what do you see from the ambulance services that are bringing in these patients into your emergency department? Hepla, can you tell us? It's okay. I'm not seeing anybody. Or will somebody write it in the chat? I want to learn from you guys. I'm very curious. Well, I don't know. Okay. Well, that's okay. I will, maybe next time we can, I don't know why it's not going. Well, Shirley, do you have anything to add?
I just wrote in the chat, just the other thing to remember on all these bleeding patients is to reverse their anticoagulation.
Yeah, definitely. And that's a great point. I did not, because there's just so much with the bleeding and depending on what the injury is and everything. But so I didn't get into all the specific treatments, but that one is important for no matter what type of bleeding is. You're absolutely right. If you can get that history, they're on Coumadin or INR, and even some of these newer drugs, we have reversal agents for that. So that's a great point. We'll wrap up since I think you guys are probably traumaed out and blood loss out. I'll just chalk it up to that. But so we'll end it here. And it was great seeing you guys. And if anybody has any questions or they want to tell me, you can also message me if you want to write me an email and explain to me. I'd be happy to hear about it. And I will send the readings again. They were in the initial outline I sent at the beginning of the month. If anybody needs me to resend that, let me know. I'd be happy to. And I will send out the Zoom link and then the questions a little bit closer to next week. So thank you so much. Have a great day.
you.